It's such an honor to be joined by Dr. Gonzalez-Conty here today, who is one of our outpatient therapists at the Motherhood Center. And doctor, there are all of these different subsets and categories within the field of psychiatry that a lot of people don't know about. And something that we're very proud of at the Motherhood Center because we're able to capture many MDs in the field that specialize in these areas. Now, you in particular specialize in an area of psychiatry that perhaps not many people have heard about, but is incredibly critical and important. And it's infant psychiatry. So I would love for you to tell us a little bit about what exactly infant psychiatry is and how it differs from general psychiatry.
Absolutely. Well, it's a pleasure to be here. I can tell you a little bit about infant psychiatry and how it focuses mainly on early relational health. So it really focuses more in the relationship between the parent and the infant. This is an area where we are usually looking to understand the infant's inner world. So through observations of the infant, through their behaviors and the way they respond to certain interactions with their caregivers, we are looking to help the caregivers understand how the infant is responding and what exactly are they saying through their behavior so that we give them the tools that they could benefit from. In this field, we're looking to understand the dyad, meaning the parent and the baby or infant or toddler. And we look to offer tools to parents to understand the meaning of the infant's behavior. The infant at first considers themselves as one entity with the mother. Right? They don't exist in the world without the mother or father. There's no such thing as a baby, meaning there's no such thing as a baby living in the world without mother. So in this field, we are always looking to understand the interactions between the mother and the baby. And that's how it's connected to reproductive psychiatry. The disruption in the relationship with the caregiver can produce a lot of different emotions in the infant that may get in the way of their energy in development. As we think about and as we understand the relationship and the experiences of the infant, we learn to understand how different emotions and feeling states of the infant can interfere with their development.
I'm so glad that you're bringing this insight and this area of expertise. It blends so necessarily and so nicely with the dyadic work that we do here at the Motherhood Center, particularly in the day program, and just the importance of attachment and bonding. I think so often there's this construct or this expectation that when a mother has a baby, that she's going to feel this instantaneous, unconditional love and bond and attachment with the baby, which is just not always the case. And to your point, that can have an impact over time if appropriate interventions are not introduced. And I wonder if you can talk a little bit about what are some of the effects and impacts of not being able to intervene on that mother baby dyad.
I think that we see, and this is why we believe this is so well integrated with reproductive psychiatry, we see how the peripartum mood and anxiety disorders can really interfere with the way a mother relates to their infant. We have seen the impact that these disorders, these untreated disorders, can have on the bonding and attachment to the infant, either because of the way they are perceiving the relationship or what the infant is receiving from the relationship. So there's a direct link. When mothers are struggling and they're unable to take care of themselves, it makes it much harder for them to take care of somebody else. So going back to the thought of the infant being completely dependent on the mother, if you think about a struggling mother and how hard it is for them to just go on with their day-to-day tasks, imagine adding having to take care of everything for another human being. So we have learned and given a lot of attention on the impact that not treating these illnesses can have on the development of the infant for this reason.
And you mentioned a lot the term and the discipline of reproductive psychiatry, of which we have quite a few very talented reproductive psychiatrists here at the Motherhood Center. And I know that, in much of the capacity that you are in here treating patients that come to us for care and support, that you are kind of merging the two areas of expertise and specialty. So tell me a little bit about how you merge your background in infant psychiatry into the work that you're doing as a reproductive psychiatrist here.
Well, I really believe that life brought me here. I trained as a child and adolescent psychiatrist after I completed my general psychiatry residency. And I eventually got to work at the Motherhood Center as I continued my training in infant psychiatry. So I was able to do subspecialty in infant psychiatry, where I was able to just focus on early childhood from 0 to 5 and do interventions, while at the same time I was able to run some dyadic groups at the Motherhood Center. One of the things that led me to going into the field of infant psychiatry was, as a child and adolescent psychiatry trainee, I got to run groups. It was mainly focused on prevention, where I ran groups of parent and young children, 3 to 5, and they were groups that would promote resilience through creative, expressive play. So I learned about the importance of optimizing these interactions to support the development of the child. So it was through this lens of prevention that I really chose this field of infant psychiatry.
So important. One of the things that certainly comes up a lot, and I'm sure you experience in your practice, is that there can be a lot of fears and misconceptions around taking medication during pregnancy and the postpartum period. Oftentimes women birthing people opt to go off all of their medications or some of their medications without a consultation with an MD, because they're afraid that if they stay on, there might be adverse impacts to the gestating fetus throughout their pregnancy. And in some instances, patients are told to go off by their OBGYN or PCP. Can you talk a little bit about some of those misconceptions? And when you do interact with a patient that has concerns, how do you approach that? How do you describe the risks or the benefits of being on medication during pregnancy and the postpartum period?
Well, I think that one of the misconceptions that women in general have is that illness is not a risk factor, that medications are more risky than the illness itself. The way I approach it with patients that are struggling so deeply that they need and could really benefit from medications, even throughout the pregnancy and in the postpartum period, is that I think about the risk that we have to consider: the risk of the untreated illness in itself and the risk of the medication management throughout the pregnancy or in the postpartum phase. And I think what we've been discovering, and especially as we see more of those cases of mothers that haven't been in treatment and they're struggling, is that the risks are even higher with the untreated illness because of all the things that could emerge from the untreated illness. But we definitely see the impact that it could have on the bonding between the mother and baby and the relationship in itself. The mothers might not be available in the same way that they would otherwise to care for their children, just because they are not well themselves. there's always a risk if there is an illness that is not receiving the proper treatment.
I understand there to be a spectrum of ways that mothers can interact with their babies. So can you talk a little bit about the different styles?
It's one of the most fundamental aspects of the work that we do, right? Understanding the way babies attach to their caregivers, because like I said before, babies don't live in a world where it's just them. They are always present in relationship to the other. Otherwise, they're not able to survive. So we have been able to identify different ways that babies attach to their caregivers. And they've been conceptualized in two sort of like areas, one being secure attachment and the other one being insecure attachment. So most babies develop a secure way of attaching, but there are some that develop what we call insecure attachment, which is more an anxious style or avoidant. And then there's another area that's more disorganized. We know that babies, in spite of these different type of attachments, that they're able to overcome some of these ways of attaching to their caregiver and thrive in spite of whichever way they attach to their caregivers, right? So we don't see necessarily that they're at higher risk for having an insecure attachment to develop any psychopathology in the future, unless their way of attaching is disorganized. We often see disorganized attachment in babies that have been exposed to traumatic situations. So the other ways that babies have developed mechanisms of attaching to their caregivers has been adaptive. They have learned of ways to cope with their environment. And sometimes that creates for a more avoidant or anxious attachment, which falls under the insecure category, versus the ones that have developed a more secure way of attaching, where they're just more used to relating to the other in a way where they can feel like there's this secure base, and they're going to look for that secure base to feel like they have an enough sense of security to then go and explore. The otherwise it might take them a little bit longer. It might be that they're slow to warm up, and that might not just be related to the relationship, but also to their temperament, because we know that babies also bring a part of themselves into the picture. It's not just about, the baby in the relationship with the mother, but there's also some genetics that contribute, and there is a baseline temperament of each individual, each baby, and that also plays a role into the way they relate to others and attach to others. So I would say that there's different ways of attaching for babies to attach to their caregivers. The one that we often see that needs more intervention, more clinical intervention, is the disorganized attachment that often has to do with external factors that have affected that baby from very early on in life.
I oftentimes will say with the new mothers that I work with, that babies are like snowflakes and no two are the same, right? Which kind of lends itself to that concept of temperament. And unfortunately, a lot of new mothers will categorize their babies as good or bad. So a bad baby is a baby that cries all the time or doesn't sleep throughout the night in long stretches, or is fussy or colicky, whereas a good baby is someone who will, take a bottle and drink 5 ounces at a time and sleep for 3 hours during the day. When you're working with patients that kind of use these labels to describe their babies, what would be an intervention or a way that you might reframe or address the way that they are labeling their infant?
That's a great question. And it makes me think about all the biases also that we have just from living in society, where we are in this constant state of like comparing each other to the norm. And like who really developed the norm? Like who was the one that actually said that this is a good baby and this is a bad baby? If you were to look at the history coming from such a long time ago, that I think, letting go of that is really important and necessary, so that each parent can allow themselves to get to know their babies with their own individualities. I think that because when life hits you with situations that you don't expect, it can trigger like a cascade of emotion, and we all go into problem solving kind of way, where people might just feel more comfortable saying, well, this is happening to me because I am just not lucky. I didn't get, an easy baby. However, I think that just is important in itself to help us identify maybe that we need a little bit more support when things aren't going the way we expected. That, I think, in itself gives us an opportunity to ask for help, to understand how we can go about this in a different way, so that maybe we can change this pattern. So I would say, in this same way that we treat mothers like the good mother versus the bad mother, and we think about that concept, right? I think we need to move away from it and know and identify more than anything when things are at least good enough. So, in the same way that we think about mothers being a good enough mother, where they're providing the baby with the basic needs in all areas, we need to think about babies in that way as well. They're just trying to survive in the world with a lot of things that are brand new to them, and some of them respond differently than others. And that doesn't mean that we need to label them as good or bad, but there can be an in between where my child is just, learning their own way to navigate the world, and I'm going to help them through that. And it might be a little bit more challenging at times, or depending on the situation, but with good support also and with help, I'm going to figure it out, because it's not just all on baby and it's not just all bad. There are good things that babies are also doing. I like to think about some of these babies that they describe as difficult babies. They are able to show some traits of their personalities really early on, because they might just not feel like that's right for them, and they're already sort of, letting the mother or father know this is not something that they want. And who knows, how that can be a really positive sign of a personality trait that eventually will get them to advocate for themselves and to really know, what it is that they want and what they don't want. So it might be something that's difficult now for the parent, while they're parenting in this world. But in the end, who knows if that baby has a lot of traits that are really positive in their either early childhood or adolescence or adulthood.
I love that description and that analogy, and reframe. And I couldn't help but think of my daughter when you were talking. It's such a, I know it can be so difficult for new mothers, first time mothers in particular. You feel like you're stuck in this place that you're never going to get out of, and it's always going to be this hard, and nothing's ever going to change. And I get that, right? If you've never done it before, it is hard to move past it. But to offer that perspective of these things that might and do feel challenging in the here and now, there's a good chance that they could actually be strengths that are currently growing within your infant. And these very things are actually going to lead them to be, you know, very strong and confident, or however they develop forward. I really appreciate that reframe. And you know, in talking about you know, successes and how effective both your field of infant psychiatry and reproductive psychiatry can be for the perinatal population, I wonder if there is a patient or intervention, something that you can recall in the work that you do, where, you know, medication in the perinatal period or your infant psychiatry intervention really made a difference and had a lasting impact. I think it can be so helpful to hear actual stories in which these areas of expertise really make a difference.
Yeah, I think that that is the most rewarding aspect of the work that we do. In the field of infant psychiatry, we do a lot of therapy, psychotherapy more than anything, and dyadic work. Most of the time, we want to work with both the parent and the child together because we're going to promote that relationship and support it. We know that there are particular instances where we might be working just with the child for reasons that sometimes are quite complicated, but that might have to do with the concern that involving the parent could be more harmful than good. This is something that maybe we don't need to go into, but to give you an example of some of the work that I've done, it's mainly been through psychotherapy and dyadic work. I had the opportunity of working with an 18-month-old toddler, and he was a young child. He was the fifth in his household and had been born to a different father than the previous four, and there was a big age gap. And the child had come into this world where he was not necessarily desired. He was developing really, he was developing ways of coping with his reality by just making himself heard. So he would scream very often, he would hit, and he would be very difficult to soothe. So he wouldn't sleep that well, he wouldn't nap during the day. And as I worked with this dyad, I realized that his experience in life was very unpredictable, that he would be in between his mother's house, where there was a lot going on with four other siblings that were much older than him, still in childhood, and struggling with their own things. And at his father's house, he was an only child receiving a lot of attention, right? So he had a big reaction to that constant change in environment. And he adapted to ways of coping with that that were not that helpful for him, or not that helpful for the mother. They were helpful for him because he learned very quickly that that was the way he would get his needs met, but it was not ideal, mainly for the mother, who was really trying to take care of five children and was really struggling. So with consistent work where we would meet with the diet, I would meet with the dyad on a weekly basis, he was able to also develop a relationship with me and with the mother that was more predictable. There was something about what I represented to him that had to do with the mother. He knew that I was able to create an environment for him that was unique and really help the mother understand his behavior in a way that she could give meaning to it, both out loud and through their interactions, by either saying with words what she understood he was saying, but more than anything, also understanding the meaning of his experiences and his emotions that would trigger the behavior that we were seeing. It was really remarkable, the transformation that then started happening in the relationship between him and his mother through the work that we were doing, where I would give mom tools to understand the meaning of his behavior. So there was a lot of play involved in this type of work, where I would just observe him through the play and understand sort of like what he was telling us through the play, which is very common. And that is essentially what we do in this field of early childhood, where we do a lot of play. We know that play is a way that children can go into situations that are very challenging for them. So they go into situations that are very challenging for them because they mainly are composed by difficult emotions. So they're able to resolve situations that maybe they weren't able to resolve otherwise through the play, and either change the narrative, and through the play they're able to share with us a piece of their inner world. We can use that to offer to them a way of resolving problems that might have not been solved in real life and that are too hard for them to just speak about. So that's the beauty about just being able to use the play in the therapy and to help the parent understand better what the child is bringing up with the play, right? What the child is sharing about their experiences through the play. But with this dyad in particular, I was able to notice that the child would surround himself with really hard objects in the play, and his play is very repetitive. So he would love to use cars and trucks, and they were hard objects, and I would see him always gravitate towards the same toys. And he didn't like for the toys to be taken away from him. He liked to surround himself by all of these hard objects, which as time went by, I was able to understand that he was really afraid of falling apart from this constant state of disintegration, like him not knowing what to expect because he would be dropped off from one house to the other quite often. He needed to build himself this armor to not fall apart in those moments where he didn't know what to expect. So he was learning ways of holding himself together. In the work that I did with the mother, a lot of it had to do with holding the mother so that she could hold the baby and hold the baby in her mind more than anything else.
Dr. Gonzalez-Conty, I'm so thankful that you shared that experience with this particular family. It just illustrates the power of the work that you do and the power of infant psychiatry, and all of the different techniques and interventions that go along with it. I can't thank you enough for joining today and letting us know about your area of expertise. We are so lucky to have you at the Motherhood Center, and so lucky to know and watch you merge two areas of psychiatry together. I only wish that there were millions of you all over the world, and certainly here in New York. But thank you so much. You did great.
Well, thank you, Paige. I appreciate so much the opportunity to just give light to this field that is sort of new,
Yeah.
right? And I think that a lot of mothers could really benefit from doing this type of work early on in the relationship when they're struggling. And I'm happy to be here at the Motherhood Center to be able to offer this. So thank you for having me.